My name is Joanne Yao, and I'm the Senior Director of Marketing for ImpediMed. Today's webinar is titled Surgeon Insights. Is now the time to start a program for early detection and intervention of breast cancer-related lymphedema? We have a wonderful panel of breast surgeons joining us today. Dr. Ameer Gomberawalla, breast surgical oncologist and medical director of informatics at Advocate Aurora Health and assistant clinical professor of surgery at the University of Illinois, Chicago. Dr. Laura Lawson is a breast surgeon at the Nashville Breast Center in Tennessee and the medical director of Ascension St. Thomas Breast Cancer Program. And we have Dr. Stephanie Valente, breast surgeon and director of the Surgical Breast Oncology Fellowship Program at the Cleveland Clinic, associate professor of surgery at the Cleveland Clinic Lerner College of Medicine and Case Western Reserve University. So today's webinar will be a live panel discussion. We encourage you to participate by submitting questions via the Q&A icon on your screen at any time during today's discussion. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we're not able to address live. We are also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your local ImpediMed representative. All of our webinars are available for replay approximately 1 week following the event. You may find them on our YouTube channel called ImpediMed Oncology. And when you're there, please don't forget to subscribe. Now I will go ahead and invite our panelists to join me on video. Hello. Hi, Dr. Gomberawalla. Hi, Dr. Valente. It looks like the only one we're missing is Dr. Lawson. Okay, well, let's go ahead and get started, and hopefully Dr. Lawson, oh, there you are. And I'm going to go ahead and have you unmute as well, please. Thank you. Excellent. So thank you, everybody, for joining. Let's go ahead and start with introductions. So Dr. Gomberawalla, would you mind introducing yourself? Tell us a little bit about your current role and practice and any interesting focus areas.
Yeah, so I'm a Dr. Ameer Gomberawalla. I'm a breast surgeon at Advocate Aurora Health and specifically Christ Medical Center in the south suburbs of Chicago. We are a group of 3 breast surgeons. I'm joined by a larger group of breast surgeons across our health system. My current specialties within breast cancer, one of my main focuses is reducing the collateral damage of treatment, and part of that is utilizing the ImpediMed Sozo system and axillary reverse mapping and lympha. So those are some things that I've been focusing on through my career. We started the program, the AH system started it around 2011, 2012, and my group started utilizing the Sozo system when it came out around 2018.
Thank you, Dr. Gomberawalla. Dr. Lawson, would you tell us a little bit about your current role and practice?
Great. Yes, I'm Laura Lawson. I'm a breast surgical oncologist at the National Breast Center in Nashville, Tennessee. My partner is Pat Whitworth, who many of you may be familiar with. He's a leader in our field and has a special interest in lymphedema also. I see 100% breast patients, all ages. I do my own ultrasound-guided core biopsies, stereotactic biopsies. I also work with the Vanderbilt University Fellowship Program and help train their fellows to do ultrasound in the office. Special interests, I kind of a boots on the ground. I really like to do programmatic projects, and I've been the medical director of the breast cancer program for Ascension for over a decade now, and really helped develop that program. We're now one of the largest programs in the Southeast. And as part of that, I helped develop our lymphedema program, our survivorship care program, our nurse navigation program, pretty much every program we have, I've been a part of that. And so I look forward to being able to talk to you all later during this presentation about really how to start a program from wherever you are, how to get that organized, and one surgeon and one lymphedema therapist is really all you need, and how to get that up and going. And then contrasting that with now in our private practice office, I have a lymphedema therapist whose office is right across the hallway from mine. So two very different systems with a private practice versus a large hospital system, but hope to be able to speak to both and help everyone gain maybe a little bit of insight and how to work within both of those systems.
Thank you, Dr. Lawson. Wonderful. Dr. Valente, would you mind introducing yourself and your current role in practice?
Sure. Good evening. Thank you for having me. I am a breast surgeon at the Cleveland Clinic, where I teach the fellowship. And so really kind of how I got started in this is advanced surgical management of lymphedema. So I think it's really important, as we treat patients for breast cancer, kind of looking forward and treating, the effects of our operation on these patients. And, we all know that a patient fears lymphedema after cancer recurrence. And so this is a huge problem. And so as I started working with my plastic surgery colleagues on trying to figure out a surgical way to manage these patients, it became natural that we said, if we're going to do these procedures, we need to monitor our outcomes. And so we started to look at the best way to look at these outcomes. And so we, kind of collaborated, looked around, and really believed in bioimpedance spectroscopy. ImpediMed has a lot of data surrounding it. And so we've been active participants in using the devices. And so I'm interested in kind of sharing how we do things at the Cleveland Clinic tonight.
Thank you. Thank you so much for your introductions. And I hope all of you attending can see what an impressive group we have here. So please don't hesitate to chime in and ask questions. We want to hear from you and answer as many as we can. So let's go ahead and get started. I think where we wanted to start is, many of you touched on the fact that such dramatic improvements in detection and treatment of breast cancer has led to dramatically improved survivorship. And as a result, survivorship has become a critical part of care, as all of you are involved. And after successful treatment, lymphedema is a very important concern. So what I wanted to start off with is, when we talk about, right, this title is, should we start a program for early detection and intervention of breast cancer-related lymphedema? So when we talk about early detection and intervention, what does that mean? What does that mean to you, and why is it important? And Dr. Lawson, I'll ask you to kick us off here.
Sure, I'd be happy to. So really, I think our goal with all of this is to prevent chronic lymphedema. We've come such a long way in being able to treat and to cure breast cancer, but we don't want to leave women for the remaining decades of their life with this giant sore arm wrapped in bandages. I mean, that's a horrible thing. We do so much good for people, and they have almost forgotten their cancer, but then they have this daily reminder by this huge arm. And so now we have the tools that we can actually, we can measure it, we can treat it, we have surgical procedures that we can do to really intervene and prevent it. And so I think that's really now where we're moving towards, and really kind of how we do that. And so I wanted to go ahead and just to kind of make sure we're all on the same page with what we're talking about. So the differences between subclinical lymphedema and chronic lymphedema, just briefly go over some of those things. So the stage 0 lymphedema, I'm sure everyone has seen the picture of the woman with the 4 different arms. We've all seen that picture, where it starts a normal arm on one side and then the huge swollen arm on the far end. And so we want to keep all of our patients on the normal arm. And so that subclinical lymphedema, we can actually detect that now with our LDEX, with our bioimpedance. And that is even before the woman notices that there's anything really going on. It might feel a little bit vaguely heavy, but not any visible swelling. And we can detect that, and then we can do something about it. And so that's what we're talking about with the stage 1 lymphedema, which is really where we want to catch things. The stage 0. Stage 1, that degree of swelling might come and go. The patient's a little bit more aware of it. When they elevate their arm, it'll get a little bit better for them. And that is at where we were previously kind of limited. We had the systems in place. We could recognize lymphedema at that point, but we're getting real close then to stage 2 lymphedema, which is what we consider to be chronic lymphedema. And so that one is, there's visible swelling. A woman has a lot more discomfort and problems with that. And we will really want to try to avoid then the stage 3, which is when that extracellular fluid gets replaced with fat and fibrotic tissue. And that's really when our treatments, we can't really do very much. And really they're just more in a chronic maintenance stage. So we're really trying to, all of this designed to catch things early when we can prevent them.
Thank you, Dr. Lawson. And Dr. Valente or Dr. Gomberawalla, when you think about these stages of lymphedema, how does treatment differ? If you're talking about, so you detect it early, you find it at stage 0 or stage 1, like Dr. Lawson suggested, what do you do?
So basically, the benefits of early detection is you'll generally refer them to a physical therapist or your occupational therapist, and specifically a lymphedema specialist, who'll usually see them for about a month, give them exercises, do massage therapy, and intervene with usually a temporary compressive sleeve, versus when it's caught in later stages, these therapies are often chronic and need to be repeated.
Mm-hmm. And what does chronic therapy look like, Dr. Valente?
So chronic therapy, these patients either wear a sleeve most every day of the week. Maybe they wrap themselves, or they have to have family members wrap themselves. They have to wear a glove or a gauntlet. Imagine trying to wash your hands even during COVID with a glove on all the time. A lot of times they're not able to wear the right fitting clothing because they need a bigger arm sleeve. But a lot of times these women are going to therapy a couple times a week, which they kind of have to manage between jobs and stuff like that. So kind of my take on this is that screening for lymphedema is just like getting a mammogram. I mean, we're screening for our risk of cancer. And so we know that in women who undergo lymph node surgery, there's a risk, whether it's lower in sentinel node or higher in axillary lymph node dissection, that these women could get lymphedema. And so screening, with bioimpedance is offering women the opportunity to, if they get lymphedema, just like if they get breast cancer, that it would be caught early, just like mammogram, where they have options. If it's caught later, then, and women don't really know what to look for sometimes, that if it's caught later, then, they are wearing sleeves and they say, gosh, I wish this could have been caught earlier.
Okay, thank you. Now, what does a optimal program look like, or a protocol to make sure that you are detecting it and treating early?
So what we do at the Cleveland Clinic is, so any patient that comes in with a new cancer diagnosis, I mean, sometimes they're going to go get neoadjuvant chemo, sometimes they're going to go to surgery first. We educate them. PetiMed has a great little booklet that we give patients in their new cancer folder. And we do get a baseline on every patient that comes in the door with a diagnosis of cancer. So that's their baseline, whether they get taxane chemotherapy or whether they get a sentinel node. And our follow-up of these patients is really based on their risk, but everybody has a baseline so that if they develop lymphedema, we've got something to compare it to.
Excellent. So then you detect them. How do you follow them up after surgery? Are you seeing them regularly? What type of visits do you see them on? What is your goal with regard to being able to catch the lymphedema after their cancer treatment?
Right. So it's based on risk. So a lot of times when we see patients post-op, that's a little too soon, but traditionally it's 3 to 6 months after, and then just kind of asking, do you have any symptoms of lymphedema? For sentinel node, we'll usually do a 6-month post-op baseline. For axillary lymph node dissection, we follow these patients closely. they all do see in our program what we call breast rehab, where they do see a therapist and follow with measurements pretty regularly. So every 6 months for the first 5 years is what we use. A little bit closely in the first 3 years, where we can do every 3 to 4 months as well.
Okay. Now, Dr. Lawson, I mean, one of the questions that we get a lot is whether all patients should be getting baseline and should be getting tested, or whether you only test patients that are at very high risk for lymphedema. And specifically, the question we get a lot is, do you think that patients who undergo sentinel node biopsy should get baseline and follow-up LDEX testing, or can you exclude those patients because their risk is so low?
Well, I don't think we can really safely exclude anyone. I mean, we'd like to, but in reality, I think all patients need to be tested. And sometimes you don't know what the future is going to hold. So you might think, oh, we're only going to be doing a sentinel node, but then that might change and they might end up having an axillary dissection, or they might end up having radiation. So since we don't know exactly what each patient's course is going to be. And there are also some other factors. I mean, certainly we think about an axillary dissection, chemotherapy, the radiation. There are different ways that the radiation can be delivered. There's some individual patient factors. What other medical problems do they have? We're finding that obesity plays into this. So I really think that probably the most straightforward approach would be, if you're going to have anything done to your axilla, you need to have testing beforehand. It is sometimes logistically a little easier. I think most of us, from a surgery standpoint, if they're going to be having surgery first, we've gotten that down pretty well of, okay, everyone who's going to be having surgery, make sure we get their testing done. But I know that sometimes if they go off and have neoadjuvant chemotherapy, that's something that I think at a lot of programs, people just need to be aware of, that, okay, at some point they're going to be having some axillary surgery. We need to make sure we have a system in place to also capture those folks.
Wonderful. Thank you. Dr. Valente or Dr. Gomberawalla, anything to add to that?
Yeah, so to the topic of today's discussion, like, is now a good time to start this program? With the advent of the Sozo machine compared to what LDEX used to be. So just for a little bit of historical knowledge, LDEX used to be this EKG style stickers that you would have to place on the patient that wasn't very seamless. And now, and why we waited a little bit, as in my personal institution, to get the Sozo machine, is because it's so easily implementable throughout a facility. So anyone can do it, and the more you utilize it, the easier it becomes for your staff. So similarly to Dr. Lawson, we will treat and evaluate all of our patients undergoing any sentinel lymph node procedure or any axillary procedure, mostly because whether it's 1 to 5% for sentinel nodes, or 15 to 20, or maybe even 30 to 50% on axillary lymph node dissections and radiation, you just never know which patient it's going to be. And this can give you at least some direction on who's going to be high risk or not. And it can be, there's a lot of talk, and even Lymphedema utilizes this, is that it can be a new vital sign. And in our practice, it's kind of looked at and taken in, just like we take their blood pressure, they're going to stand on this machine for 30 seconds and we're going to get this breast cancer vital sign for them.
Thank you. Thank you. And Dr. Valente, you talked about getting a baseline on all of your patients as well. Do you do that simply post or pre-surgery, or do you try and get those before neoadjuvant chemotherapy begins as well?
So we actually, again, a lot of it's just workflow. So initially we're trying to be judicious with it and said, okay, anybody who gets an axillary lymph node dissection and then, they get a workup and then you're like, oh, we forgot, so then it just kind of became exactly what Dr. Lawson said. It's just easier to get it on everybody, because then if somebody has symptoms later, you're like, did I get it? Did I not get it? So, when the patients walk in, there's a scale, they stand on the scale. There's the Sozo machine, they stand on the Sozo. And in our electronic medical record, it's charted just like that. So you can actually see just next to like the blood pressure, exactly where they are. So you're not kind of fidgeting with that. So we've kind of just built it in. So it's really easy for us to manage and look at it.
Thank you. I think that's pretty consistent across the board that you're all trying to just get the testing on everybody up front. With Sozo, it's easy, which is great. Now, Dr. Gomberawalla, was wondering if you could take the next question here, which, is there any evidence? I mean, you started to allude to it, but would you just talk a little bit about what evidence supports actually even doing this type of protocol?
Right. So I guess without getting into making this into like a didactic lecture and going through multiple different papers, this probably first starts with and probably ends with the PREVENT trial, to be honest. So most of the people on this call are probably familiar with bioimpedance spectroscopy and early detection, whether it be tape measure, whether it be bioimpedance spectroscopy for subclinical lymphedema. In general, we know that early detection leads to better outcomes, and pretty much across different disease states. So if we just focus on lymphedema, now is a great time to bring this evidence up to your, hospital administration or colleagues, private practice managers, because we, at the minimum in 2019, have the interim analysis for the PREVENT trial, which was a randomized control trial between tape measuring versus bioimpedance spectroscopy. And the 1 year an interim analysis demonstrated quite a significant reduction in both the amount of patients who were triggered into receiving that 1 month of therapy that we talked about earlier, as well as the progression of lymphedema. And to give some rough numbers, it's something along the lines of like 28 to like 15% versus on the trigger side. And then for the progression side, about a 14% versus 7%, again, in the interim 1 year analysis. And we're looking forward to the publication of the final PREVENT trial once that comes out. And secondly, another piece of evidence that most of us use as like kind of gold standards of evidence is a meta-analysis. And recently in 2020, Dr. Shah published a wonderful meta-analysis of about 50 studies, which included about 67,000 women across the board, all pretty much demonstrating the same thing, that bioimpedance spectroscopy, compared to all other methods of lymphedema detection, found a lower long-term lymphedema rate overall. So, and those rates roughly, 7% to down to 2% in the meta-analysis. So, without going into further detail about like specifics of different papers, I think that because you have both a meta-analysis as well as a potential, and by the time you'll probably, approach your hospital administration or practice providers, I'm hopeful that the long-term PREVENT trial information will be out there. I didn't use the word long-term, but what I meant, in addition to long-term stuff, anecdotally, we've been utilizing it in the AH system for about 8 to 9 years. And from that long-term data, we've had, it's not just the first couple of years, long-term, it does carry over.
Okay, thank you. And, do any of you, many of you have been using these technologies for a while. One of the questions we get a lot is, what's the longevity of this? If you're following patients through 3 years and treating them, and I mean, are you seeing that we're actually able to resolve the lymphedema and that is a durable outcome? What's your experience there?
So, my colleague, Dr. Heidi Memel, has been utilizing it at her hospital, Lutheran General, in the advocate system since around 2011, 2012. And her lymphedema rate is roughly around 2 to 3% over the course of these years. So we're in the process of evaluating this and publishing one of our more long-term series on this. So while there's no robust data just yet across, like no multi-centered trial, but since the Sozo machine has come out, there's been a large number of institutions adopting this technology because it's no longer cumbersome. It's no longer something you have to train for. And we'll get to cost later down the road, but it's something that's cost effective. So it's kind of like a win across the board. So I'm hopeful to see more long-term data, but right now it's mostly anecdotal, small series.
Thank you. Dr. Valente or Dr. Lawson, anything to add to that?
I mean, I think if you look at it, the risk, 75% of women who develop lymphedema will do so in the first 3 years. So, we kind of look at it as, yeah, there is that 25%, but you have to maximize screening in the population that's at the highest risk. So we do kind of target those first 3 years, and then use it. And I think patients are excited to use it to see actually how well they're doing in treatment, to see if treatment's working, or if it is progressing through treatment. It helps us figure out how to change treatment for these women. But at least, 3 years for sure.
Thank you. Thank you. Thank you for going through that. And we started to talk about your programs specifically, and I'm happy to see we're getting a lot of questions through Q&A following up on some of our protocol discussions. So let's talk about your programs that you have in place today. Dr. Valente, I'd like to start with you. Any color you can add? You started to outline your program a little bit, but any more color that you can add about what techniques or technologies you evaluated before deciding to use Sozo with LDEX for early detection? What other specialties are involved? You mind talking a little bit about that?
Sure. So we're a large academic center. We do kind of span Northeast Ohio with a lot of different hospitals within our system. So the surgeons go to different places. As we started looking at our operative, what are we doing operatively wise? We teamed up with plastic surgery, number one, and then radiation oncology, number two, and then brought in our occupational therapist and our physical therapist. So we actually created what we call a lymphedema program. And part of that program, we have monthly meetings, and we've learned a lot from each other. I think that's, kind of like we're in our bubble. And so we kind of learn who's going to actually test. So we decided, okay, I see the cancer patient first. All screenings are going to come through me, or not me, but just the breast surgeon. And then, if they're getting followed up, if they've had a lymphovenous bypass, then they're getting followed with plastics, and then even bringing rehab in. And some of our rehab centers don't have Sozo. So Sozo's at our hospitals and our ambulatory surgery centers. And so the therapists were saying, okay, tell us, how do we use that information? And they do like tape measurements. So we do let them do that part. So that helps them feel like they're doing their part. So patients actually get both. If they go for treatment, they get their circumferential arm measurements from therapy, and then when they come to see us. But any patient who's had tested at any point can stop by one of the hospitals to get tested. Again, just to kind of see where they're at. And any of the providers, even our survivorship providers, our medical breast team, because not all the surgeons see their patients for 3 or 5 years, are on board, and they screen patients as well. So we've, over time, it didn't happen overnight at all, but we've developed this program, kind of got buy-in, and really are learning from each other on kind of best practices and kind of, our own flow sheet on when we send, to therapy, and when patients are progressing, when do they send to plastic surgery for lymphovenous bypass or lymph node transfer. So we're learning from each other, but it is a big program, but it did start small, and that's kind of what we're going with right now.
Thank you. Thank you. Dr. Gomberawalla, now your practice setting is slightly different. How do you run the program? What's its current state, and how might it be different, at Advocate Aurora Health as compared to a large university system like Cleveland Clinic?
So it started with Dr. Heidi Memel was the kind of medical director, but she currently still has the system housed in her physical therapy office, or like her group's physical therapy office. So it's a separate physical therapy, and her practice pattern was such that she would refer all of the patients who were getting axillary surgery over to physical therapy. So we looked at that as an option, and we said, given our current state, we're going to be missing a lot of patients. Patients don't want to go to another office. They're already tired enough that they have to see 3 different doctors to treat their breast cancer. As afraid of lymphedema as they are, we want to try and make it as convenient as possible. In our practice setting, the breast surgeon kind of leads the cancer treatment and And in probably most institutions, and from a private practice standpoint, I bet that that's the case. If you're a specialty breast surgeon, you're probably taking a leadership role in their care. So when around 2018, when we introduced this concept here, I was a big proponent to put it in our surgeons' offices. That's the people who are going to be utilized most. We can be the gatekeepers. We're going to see them. And because of all of our interest in this reduction of collateral damage, we're all on board. So we have it, and we have 3 different offices, outpatient offices where we see our patients. And our cancer center is connected to these offices, but patients would generally, if they got seen in the cancer center, like a new diagnosis, they would just walk over to our follow-up offices and then get that test done. So it is housed in that. An MA then does come and walk them through just like a vital sign. And similar to, I think Dr. Valente was mentioning, our patients are free to come in and utilize this as like their, if they want to ever check their blood pressure, they could come to our office. I mean, they don't ever want to do that, but if they ever wanted to come in and check their version of it, check their LDEX, they say, hey, maybe I feel funny or something. They'll just walk in. They have a great relationship with our staff. They don't need an appointment. And then it's a new data point that we can collect. Now, people didn't take a lot of advantage of it because, again, they have a lot of office visits already. So our typical program would be pre-op. Post-op, we would do it just to get data to show that it did not falsely elevate post-op. You didn't get like this huge number of false triggers. So that's been our experience. And then we would do it 6 months, 12 months, and then every 6 months for the first 2.5 to 3 years, and then annually after that.
Thank you. Hey, we got an interesting question for you over Q&A.
Mm-hmm.
Are you aware of any other major hospital systems in the Chicagoland area with these types of programs?
So I believe that Northwestern has this, and I don't know. I know that they have a couple of Sozo machines. I haven't been in direct contact with them recently, but I know that they attended one of our lymphedema prevention courses, and ours, I mean, the American Society of the ASBS had a prevention program that, we went over axial reverse mapping and lympha. So I did get a chance to talk to one of the breast surgeons there. So Chicago, in Chicago, Northwestern does, I believe, have these. I want to think we were one of the few, but I don't know any large system that has this program, and definitely not the longevity, because I know that Dr. Heidi Memmel has been using it for a long time, and we have a relatively robust program within our group. So.
Absolutely. And, I think it's probably a patient who asked that question. And for any patients that are on this webinar, I do want to make you aware of a resource. If you visit our website, impedimed.com, you'll see a find a provider page. You can go there and enter your zip code, and you can find LDEX providers near you. And if you have any issues with that, don't hesitate to reach out to us, and we'll help you get in touch with an appropriate provider. And that service is available for anyone in the US. If you're not in the US, get in touch with us and we'll get you in touch with a local contact in your country. So thank you for that question. Dr. Lawson, would you mind talking a little bit about your program? And, we did get a question about where Sozo is kept and who's responsible for performing the tests. And many of you talked about already, you keep it next to the scale. Mostly you have MAs perform the tests, but would you mind talking a little bit about some of your program implementation and how you've been able to make it successful in your practice?
Sure, I'd be happy to. So initially back in 2014 or 15, when we were doing the LDEX testing, was back with the lead, like the EKG leads. I was curious as to what was currently happening for our patients, because we had active lymphedema therapists. And so I went with them and we went over to the main hospital physical therapy department. And so we walked by all the men doing rehab for their knees and their hips, and our lymphedema therapist was sort of in a room in the back. And I thought, no, this is not what we want here. And so we actually got buy-in from administration, because we really were able to present it as, and this was before survivorship care was even a thing, but really that we want to provide a full service for our patients. And we know that what we're doing for their treatment is causing lymphedema, so we need to help. And we had a lot of buy-in. Everyone was really supportive. And so what we did to start with, literally one lymphedema therapist worked with my patients, and we looked at what days I was in clinic, what days I would see the most patients. We had an extra room in our clinic, and so she started to see patients there. And then we thought, well, how are we going to capture patients? So we did a flow sheet. We brought in our nurse navigators. And so then when the patient was scheduled for surgery, that triggered a referral for the nurse navigator and the physical therapist or the lymphedema therapist. And then when the patient came in for their pre-op testing, they would meet with the lymphedema therapist, have their baseline measurements, they do their pre-op testing, get their garments, meet with anesthesia. You know, we have a lot of patients that come from a couple hours away. Tennessee is a really long state, and we see people coming in from both directions, from north, from south. So we really wanted to get a lot done on that one visit. And so then once we got the flow down to my patients, then we said, okay, there are 2 other surgeons in my office. Let's branch out and have them start using it. And then we thought, okay, well, we also have other surgeons that are on this campus. All right, let's bring them in. And it kind of grew and it grew. And so now it's, you know, different hospitals we've been able to replicate. Okay, what works at, we kind of have one main hospital where most of the breast surgery happens. So we kind of, that's sort of our incubator till we get things set up and going, and then we branch it out and have our other hospitals be able to implement those same programs. And so now when the patient's getting ready for pre-op, then they meet with the lymphedema therapist and have those measurements made. And that's a little bit, that's in our program that is a lot of different private practice surgeons, employed surgeons coming in from a lot of different locations. In my current private practice at the National Breast Center, as I mentioned before, our lymphedema therapist is actually across the hallway. And so that is a little bit easier, but I realize not everyone's going to have that to be able to do that. And so we actually moved the Sozo machine. It's right next to the scale. And so they come in and it's just an extra vital sign that they get. And then Andrea works with patients, and we really use the Sozo machine to identify patients. And then we have a lot of outstanding therapists that are out in the community. So then we refer patients out to, you know, because most of them aren't going to be able to drive the 2 hours back here to have their therapy. So we've really worked hard to make sure all the surrounding communities that have their lymphedema therapist are on board with kind of what we're doing, and they can do whatever measurements they need. But once we've identified patients, then they go out to the other facilities and then come back and have their checks to see, okay, you know, your LDEX score was up. What is it now? Has your treatment been successful? And then they come back in. So kind of 2 different types of programs that we have that are both going, and both work equally well. I think really the important thing is you just have to, you need a lymphedema therapist who's really active and engaged and willing to work with the surgeons, but probably most importantly, a champion of the program. And usually that's going to be your breast surgeon.
Mm-hmm. Thank you, Dr. Lawson. So really appreciate getting a view of all of your programs. And, you know, I'm going to kind of go back to some of our earlier discussions about workflow, because we're getting a lot of questions here, and we have some about the technology, we have some about workflow, we have some about the relationship between surgeons and therapists, and then we have some about billing. And so why don't we tackle kind of each of those in sequence? So one of the first questions is around, you know, around bioimpedance itself and LDEX itself. And one of the questions is, does bioimpedance pick up axillary cording and Webb syndrome? And at what stage do you classify axillary Webb syndrome? So I'll take the technical question. Bioimpedance picks up fluid. So what we're looking at with LDEX is a measure of the fluid in a patient's arm that's at risk for lymphedema and comparing it to another arm or limb that's not at risk for lymphedema. And in that way, we do get the LDEX score, which is an index and has been shown to be very 80% sensitive and 90% specific at detecting subclinical lymphedema at that 6.5 change from baseline. So that's how LDEX works. Any comments from any of you on at what stage does the Webb syndrome develop?
I think it's a good question. I don't know if there's an association between the development of axillary Webb syndrome and subsequent lymphedema. I can tell you that if somebody does have a Webb, we do send them to therapy, and usually massage over time, a couple of weeks will actually fix that. But I don't know if those patients are at any increased higher risk for developing lymphedema. We do not give them a sleeve because they have a Webb. But I'd be interested in seeing what Dr. Gomberawalla and Dr. Lawson think.
I don't think that's something that we see real often. I mean, certainly we'll see the cording that usually happens pretty soon after surgery. And anecdotally, I don't see a big relationship with that and the development of lymphedema. The thing we see a lot is just a seroma. And, you know, we'll have women that have chronic seromas that have to be drained a lot. But interestingly, that seems to be more of a post-op thing and not so much a thing that leads to the chronic lymphedema. But I think you need well-trained lymphedema therapists to deal with all of those aspects of the care, to do the directed massage, whatever it's going to take, and just really to reassure the patients that, okay, you know, we'll keep following you. Hopefully this will get better, but if it doesn't, we'll keep doing our measurements, because we're oftentimes watching for a couple different things at the same time.
And to kind of give my 2 cents, I would agree with both Dr. Valente and Dr. Lawson that basically, to answer that question more directly, I don't think cording/axillary Webb syndrome falls under those stages of lymphedema, so it wouldn't be categorized as that. In regards to cording, I actually think it's a very interesting concept. I actually have talked to my physical therapist, talked to a number of different people. We actually don't know what exactly that cord is. We've all felt it. We've all gone there. We feel it. We're like, what is that? Is it a vein? Is it something? We don't have a great answer to that. So in that sense, fortunately, because cording, I think, is quite a bit more common than, lymphedema, especially particularly after a sentinel lymph node biopsy, it is hopefully self-resolving. It does, doesn't create long-term effects. And in my experience, those patients who do have cording will not have an increase in their LDEX score.
Thank you. Thank you. And another question about LDEX score. Does chemotherapy affect it? Have you guys experienced chemotherapy impacting the LDEX score?
So we do know, historically that taxane-based chemotherapy can increase lymphedema. We actually at the Cleveland Clinic are trying to look at that, because we do send our patients, all cancer patients, before they get treatment, to see, is there a correlation in their pre-op? Because when we see them, then I try and get them on the Sozo machine after chemotherapy before they go to surgery. So we are actually trying to look at that. I don't know how clean the data is going to be, if we're going to be able to get some good results from that, but that's a great question, and we're trying to look at that ourselves right now.
Thank you. Yeah, and also, in the PREVENT trial, our typical protocol for follow-up that the company advises is based on the LDEX clinical practice guidelines, which were published in 2016. And that's LDEX score every three months for the first 3 years following surgery. And if you look at the PREVENT trial protocol that Dr. Gomberawalla referenced, they did not test at the 9-month visit, and that was simply because of concerns about interaction of taxane-based chemotherapy that those patients would be undergoing, and they didn't want that to create false triggers in the trial in either the LDEX arm or the tape measure arm. So there definitely can be some effect there, and it's something for anyone interpreting LDEX to consider, is what's going on with that patient. And Dr. Valente, it's great to hear that we're going to see more research on that coming out of your program. Okay, so we are getting a lot of questions about the interaction between surgeons and therapists. And, a couple of you talked about all of you talked about you're doing LDEX in your practice. You're also referring out to therapists. So the question is how important is it for you to have the therapists that you work with have Sozo and be taking LDEX scores? And then how do you share information with them? Is there a back and forth flow that takes place?
Yeah, I can comment on that. So I actually have in preparation for this, have talked with our lymphedema therapist to get a little bit more information. And that was one of my questions. I mean, in an ideal world, every physical therapist, or every physical therapy department, every lymphedema therapist would have a Sozo. That would be amazing. In reality, we're not there yet. And so I think we really need buy-in and help. This takes a village effort. And so if there's sort of a central hub, which most surgery practices, the surgeon is kind of the one that makes all the referrals out to everyone. Sort of the same thing with the lymphedema program, the sort of the main therapist is associated somehow with the breast surgeon. And then if the Sozo measurements are done and we see those changes in the LDEX scores, ideally everyone would be able to come back and have their treatment with our person in our office, but that's not really reality. I mean, so you're going to have to utilize whatever everyone else is bringing to the table and working, with the therapist that, is 2 hours away, and then when they're coming back in for their treatment, then we can say, oh, okay, you're here for your follow-up visit. Let's do your measurements again, according to the protocol. And then we can see, oh, has that therapy been successful or not? And then some follow-up, but you probably need sort of a driver of the ship from the surgery standpoint, as well as the lymphedema standpoint.
And just to kind of follow up on that, I can give our example because we have two different hospitals that are really utilizing this. One that's in our northern Chicago area with Dr. Memel, that's housed in our physical therapy department. Ours is offered in our offices, and we were both seeing benefits of each. So right now, Dr. Memel is trying to get one in her office, and we're trying to get one in our physical therapist's office but what the common feature of all of these is, and it's really going to be a surgeon champion or some type of champion of this from the medical side, from a physician side, and a lymphedema therapist. Those two are key to the success of this. Where it's housed, where it's easier. Dr. Memel has a successful program in her group. I have a successful program within ours, so it can be housed either way. Billing is part of that conversation. They have a little bit of an easier time billing. We have a little bit of a more difficult time billing, which is, we can maybe get to that as a separate discussion. But there are pros and cons to each. But as long as one of the groups has it, then you can see progression. And you're hopefully having that back and forth communication with your referring provider. If you are on both ends, from the physical therapy side, you're talking with your surgeon who's referring you. And as a surgeon, you're talking with your lymphedema therapist to make sure that, this is being followed accurately and, objectively with bioimpedance spectroscopy, hopefully.
Thank you. And Dr. Valente. Okay, so here's a question we've had. We got this before the webinar. We've got it during the webinar. For our therapy audience that relies on getting referrals from surgeons, some of them are struggling to get surgeons to refer the patients to them to be involved in this type of program. What barriers might exist to surgeons being willing to do the referral? And then what advice can you give them on how to overcome those barriers and convince the surgeons to participate in this program?
I think you don't know what you don't know. Sometimes for surgery, we'll do surgery and we say, gosh, we have a low rate of lymphedema. Maybe we only follow our patients for 6 months, or that patient goes and gets treated and we have no idea, and they don't want to tell us that they're having issues. So when they come see us, maybe they don't wear their sleeve when they come, or, issues like that. So this whole program, it's about creating teams. And, what I do in the OR and how I manage the axilla is completely different on how these therapists approach patients, what they teach patients. And so I think, it's really collaboration. I'm like, am I telling patients the same thing that the therapists are telling the patients? And are we on the same page? And what can we learn from each other? And so I think it's a really good opportunity to create teams and just say, hey, tell me what you're doing. Tell me when you want to refer patients. This is what I'm telling patients. This is what I'm offering patients. Because sometimes as a surgeon, we'll send somebody to therapy and we have no idea, because they're not, connected to our electronic medical record, what actually happened during that session. So again, I think communication is key. So if you just say, hey, this is what I'm doing for patients, and same thing, you know, when we're doing the lymphovenous bypass, the axillary reverse mapping, our therapists are telling us, like, what restrictions do you want us to follow? This is kind of our protocol. And so we've gone back and forth, but I think it's really a collaborative effort of continued education, open communication. And it can start with, it doesn't have to start with the surgeon. It can definitely start with the therapist reaching out and saying, hey, I'm noticing this. I think this is important. Tell me about how you're doing this. And that's an open communication.
Thank you. Dr. Lawson, Dr. Gomberawalla, anything to add to that? I'm hearing communication is very important, and, you know, both proactively, hey, this is what I'm doing, and then also following up on patients. Can you talk about that a little bit, Dr. Lawson?
Well, I was thinking too that I would hope that it would be less of an issue going forward to get surgeons to realize they need to be doing this, because it's pretty clear. I mean, the NCCN guidelines, it states recommend baseline and periodic measurements. You know, our program went through our NAPBC reaccreditation, and another hospital that I treat patients at recently did theirs. And it's one of the standards in the NAPBC that you have to have a lymphedema program. And so I would hope that as the majority of people, you know, have some of these programs and follow some of these guidelines, that it should be an easier sell from the lymphedema therapist standpoint of, we're supposed to be doing this anyway. So hopefully over time, then that word will percolate out that, okay, yes, this is a requirement. This is a no-brainer. Yes, we have to do this, period. Let's work together and get it started.
Thank you.
From a practical standpoint, you know, we deal with a lot of different physical therapy departments. One thing that's made it easier for us is kind of a standardized form of referral, so that we can just sign it and send the patient off should they have any sort of diagnosis. So if I was a physical therapist starting a practice or trying to engage a surgeon or a surgeon's office, I would approach that surgeon's office and say, hey, here's our referral, you know, like, here's our referral sheet. And all they have to do, if they find a patient who needs this treatment, just sign right here and send them over, and we'll be happy to take care of them. So trying to do that, make it
So
easy.
the therapy office is providing the referral sheet to you.
That is so I'm just saying, if I were a physical therapist in or in like the Chicagoland area, and I saw that, hey, there's a busy breast surgeon, how can I engage them? I would try and set up a meeting, introduce myself, and then have a pre-written referral or an order or something like that. And then, you know, that's how medicine's practiced at the moment. You just kind of sign a sheet that has your, you know, as a referring provider, and you send it over. So make it easy on them from that end. And then the communicate, they'll see, like, you'll get, I mean, the therapists are like the unspoken heroes of all of this. You know, I know that there's probably not one on this panel, but there absolutely should be. I saw one of the questionnaires by one good friend, Michael, who's a therapist out in New York. You know, they know more than anything that they're really championing this whole concept.
Okay, thank you. And I've got two burning questions I want to ask, and then we'll go to closing remarks here because we have 8 minutes left. First question is for you, Dr. Valente. You said that you test patients every 6 months. Question is that sufficiently frequent to pick up subclinical lymphedema?
That's a good question, and I don't know if we 100% know the answer to that. But I think Dr. Gomberawalla talked about it. You know, patients don't want to come that frequently, so we tried to set it up so that's when they're either seeing the medical oncologist, surgeon, or survivorship. So that's when we collect it as just at their appointment. So we try not to give them extra appointments unless they're triggered and they're actually getting treated for lymphedema. But if they're just getting screened, then we just include it as part of their screening follow-up.
Okay, thank you. And question about billing. So we talked about at the beginning, you guys are testing everybody, right? You even said it's easier not to try and select patients, because then you have the baseline. After they go through treatment, you know which ones then need to be followed up, but you may not know that at the time of diagnosis. So if not all insurances cover all patients, how can you test everybody? So we got that question quite a few times. So maybe each of you could talk quickly about how you handle billing and how you make sure that you test everybody and still handle the billing aspect of it. Dr. Valente, why don't we start with you?
Sure. Being part of a large academic center, the good thing and the bad thing is I don't really work with billing too much. So we do, bill out in our electronic medical record for the patients that are at risk for lymphedema with the cancer diagnosis. How much gets reimbursed and who gets, how that it happens, I'm not quite sure, exactly how that works, but, that's what we do. And I haven't heard issues from our patients, so I'm not really good to ask that question too.
Well, thank you. Thank you for your for your transparency. Dr. Lawson, you're in private practice at Nashville Breast Center. How do you guys handle it?
Well, so I have sort of my two different hats. So one is my Ascension St. Thomas hat. And with that, again, it's similar to Dr. Valente that the billing was sort of just a black box in the sky. I do remember that we would charge patients a nominal fee. And we never got a lot of feedback, either way. So it didn't seem to be a huge loss, or someone would have certainly alerted us to that. In the private practice world, it's a little bit different. And certainly Dr. Whitworth is the expert on this, probably across the board. But we charged, before we had a good sort of system in place and before we were working real closely with ImpediMed to figure out a way to help get assistance with some of the billing, we did charge patients if their insurance wasn't going to cover it, just a nominal fee, more so because with our therapist in the office, we have to at least sort of break even to cover those costs. And that actually worked very well for a long time. But now that it's being better reimbursed by more carriers, that's gotten a lot easier. And then working especially with the ImpediMed program of, if we're getting denials, we now have kind of a form letter that we do. We send the form letter, the records, and then we get really some assistance with helping that. And that it's sort of the thought of, if we continue to almost bombard these insurance companies that aren't carrying it and say, oh, well, this group covers it and this group covers it, that hopefully eventually everyone will get on board. But it just takes some time to do that. But I think at a minimum, most programs can usually get it to at least a break-even, reasonable venture for them.
Yeah, and for anyone who's curious, Dr. Lawson's partner, Dr. Whitworth, did share their practice economics at our November reimbursement webinar. You can find that on the ImpediMed Oncology YouTube channel. And they're definitely more than breaking even on the coverage that they get at this point. And then they're working with ImpediMed's case assistance program to appeal denied claims, and they're not charging patients for denied claims. So if you have any questions about that or want to get involved in our case assistance program, please talk to your local representative or email us at reimbursement@impedimed.com. Dr. Gomberawalla, we've got 2 minutes left here. Comments on billing, and then just any closing comments on best practices for anyone on the call that is still on the fence about starting one of these programs. Any words of wisdom or advice?
Yeah. So, I've of the group, I probably have a large experience with billing. It's actually led to a halting of our program temporarily because patients were getting denied, and our institution has decided that nominal fee to be quite large. So, you have to, the way this works, if there's a procedure that you're doing, you have to bill for it. If it gets denied, the patient has to absorb that cost. And then, so it's up to your institution. And if you're private practice, it makes it easy. You can decide how much you want to pursue. It could be $1, it could be, $500. But really, even if it was $1, you'll break even because of not break even, you'll continue to, it'll be more economically beneficial to your group because of how much Medicare does reimburse for this. So I'll leave it at that it's economically sustainable, and make sure that you have the correct nominal fee that makes sense for your practice, and even $1 is adequate enough. in terms of closing arguments, in terms of is now the right time. So I would say that now is the perfect time because number one, you have Sozo, which the technology has come so advanced that it's become an easy vital sign that's universally applicable, that any person in your office could take this, do this, and it can seamlessly integrate within your EMR if that's possible. And even if it's not, Sozo has the capability of it comes with a cloud. So regardless, we have 3 different offices. If a patient goes to any office, that Sozo is still tracked across offices. So that's probably a great thing that we didn't actually even get a chance to touch on. And then lastly, you have all the different aspects of the evidence. You have a meta-analysis, you have a upcoming randomized, multi-center randomized controlled trial. So you have economics in your favor, it's easy to perform, and you have the data to support this. So now is a great time, and you need a physician and you need a physical therapist. And then from there, you can, then you need ImpediMed as a partner.
Thank you. Any other last advice, Dr. Valente?
Dr. Gomberawalla summed it up really good. I echo that.
Excellent. Dr. Lawson, any last words of advice for anyone?
I would echo that as well. And really that now that we have the tools that we can detect lymphedema when it is reversible, I think it's a disservice to our patients if we're not testing them, if we're not finding out that information and really doing our best to give them the best possible survivorship that we can.
Thank you. Well, listen, thank you everybody for joining so much. It's a real pleasure, and we're really honored to have the 3 of you take the time to talk to us and talk to our audience. To those of you still on, our next webinar will take place June 9th. It is going to be an ImpediMed Academy webinar focused on how to use Sozo and take advantage of our new software version 4. Software version 4 is due out in late May. So keep an eye out for that software update, talk to your team, look out for emails for us. And it will come with a redesign, new features, reference ranges for body composition, a new segmental analysis. So there's a lot coming with that software, and we're really excited to roll it out and talk to everybody about it. So again, thank you all, Dr. Gomberawalla, Dr. Valente, Dr. Lawson. Can't thank you guys enough for your time. And goodbye, everyone. I hope you have a good evening.
Thank you.
Goodbye. Thanks, Joanne.